what are the relations of the different surfaces and borders of the thyroid gland? You know, this surface is called the anterolateral surface or superficial surface. This surface, it is covered by some muscles. That muscles are below the sternum. From sternum to thyroid cartilage, that muscle is called the sternothyroid, then sternohyoid, then sternocleidomastoid, and the superior belly of omohyoid. So there are four muscles which overlap the anterolateral surface or superficial surface of the lateral lobe of thyroid gland. And these muscles are, I am repeating once again, sternothyroid, sternohyoid, superior belly of omohyoid, and this sternocleidomastoid. And on the posterolateral surface, here, the main structure related is the carotid sheath, which contains the carotid artery, internal jugular vein, and vagus nerve. So these three structures within a covering or envelope called carotid sheath, which is related to the posterolateral surface of the lateral lobe. But medially, on the medial surface, it is concave because it is placed on the trachea and larynx. Because of this surface become concave. So we will get two tubes. The larynx becomes trachea, pharynx becomes esophagus, and two nerves, external laryngeal nerve and recurrent laryngeal nerves. And two muscles, one is cricothyroid and another one is inferior constrictor. So these two muscles, two nerves and two tubes, they are present or they are related to the medial surface of the lateral lobe of thyroid gland. If the gland enlarges, it may press on the trachea, it may press on the pharynx or esophagus, thereby it may cause difficulty in breathing or difficulty in swallowing. So it is an important sign of enlargement of thyroid gland when the patient complains of difficulty in swallowing or difficulty in breathing along with the swelling of the thyroid gland. If you can see from outside, it is usually due to the enlargement of the thyroid gland towards its medial side, compressing these structures. Then relation on the anterior border. Here there is one artery is there. Suppose this is one artery, it is called superior thyroid artery, which is a branch of the external carotid artery. Here it divides into anterior branch and posterior branch like this. The anterior branch or descending branch, it follows the anterior border, and the posterior branch, it follows the posterior border. And this anterior branch, it follows anterior border up to the upper border of the isthmus. And similar thing happens on this side also. So on the upper border of the isthmus, there is the anastomosis between the descending branch or anterior branch of superior thyroid artery of both sides. And posteriorly, along the posterior border, this posterior branch of the superior thyroid artery, it anastomoses with the branch of inferior thyroid artery. Inferior thyroid artery, it passes upwards, forming a loop at the lower pole of the lateral lobe, and inferior thyroid artery is a branch of thyrocervical trunk, and this inferior thyroid artery is having relationship with the recurrent laryngeal nerve, and the superior thyroid artery, it is related with the external laryngeal nerve. But difference is that the superior thyroid artery and the external laryngeal nerve, it is away from the apex. When the nerve and artery approaching towards the apex of the lateral lobe, they are going away or apart from each other. So when you ligate the artery during thyroid operation, it should be ligated close to the apex so that nerve is escaped. But in the lower pole, the inferior thyroid artery form a loop. Here the regular laryngeal nerve may be in front or may be in behind, but they are close to each other. This nerve, that is regular laryngeal nerve and inferior thyroid artery, they are close to each other towards the lower pole. But if you trace the artery and nerve, you can see the nerve and artery, they are going apart. So this inferior thyroid artery should be ligated away from the lower pole of the thyroid gland to escape the rectal nerve. This is very important from practical point of view during thyroid surgery. So now we know there are two arteries, superior thyroid artery, branch of external carotid, and inferior thyroid artery, branch of thyrocervical trunk. Another artery may be there called arteria thyroidea ima, which supplies the lower part of the isthmus. It is not always present. If present, maybe a branch from the arch of the aorta or buccocephalic trunk. It is present usually in 3% of cases, and it supplies the lower border of the isthmus. And other arteries may supply the thyroid gland are tracheal and esophageal arteries. And regarding the venous drainage of the thyroid gland, the veins, they do not accompany the arteries, but there are superior thyroid artery and superior thyroid vein, inferior thyroid artery, inferior thyroid vein, but middle thyroid vein is there, but no middle thyroid artery is there. Superior thyroid vein, it drains into internal jugular vein. Middle thyroid vein, it drains into intrajugular vein. And when the middle thyroid vein drains, it crosses the lateral surface of the gland, and then if it is intrajugular vein, it drains into intrajugular vein. But inferior thyroid vein, it drains into the usually buccocephalic vein of the left side, or maybe in the superior vena cava. And other vein maybe sometimes they are called Cocker's vein. This Cocker's vein also called the fourth thyroid vein. If it is present, it drains into the internal jugular vein. So these are the arteries and veins of the thyroid gland. But the one thing to remember that the middle thyroid vein among the veins of the thyroid gland, it is wider and it runs horizontally. And you have to ligate all the veins and all the arteries during the surgery of the thyroid gland. And another important lesson on the posterior border of the thyroid gland is the parathyroid gland, which are 4 in number, 2 on each side, 2 on left side, 2 on right side, one superior, one inferior. The superior parathyroid gland, they are more or less constant in position, but the inferior parathyroid gland, they are inconstant in position. During thyroid surgery, the posterior border or the posterior part of the lateral lobe not to be resected to keep the parathyroid gland intact. Otherwise, there will be a chance of hypoparathyroidism. That's all regarding the anatomical features and some important blood vessels of the thyroid gland.